Good afternoon, everyone. My name is Johnette Payton, and I am the Health Promotion Project Manager here at North American Management. I would like to thank you for taking time out of your busy schedules to be with us this afternoon. We are very excited to have two dynamic speakers on the subject of health literacy joining us today. First, we have Mr. Michael Villaire, Chief Operating Officer of the Institute for Healthcare Advancement, who will provide an overview of health literacy. Michael produces the Institute for Healthcare Advancement's annual Health Literacy Conference. He has written numerous articles and lectures nationally on health literacy. He is co-author of the textbook, Health Literacy in Primary Care, a clinician's guide and the easy-to-read self-help health book, What to Do When Your Child is Heavy. He is adjunct faculty at Brandman University, where he teaches a health literacy course for the Master of Science in Health Risk and Crisis Communication program. His background includes 20 years as an editor in healthcare publishing, including peer-reviewed journals in nursing, hospital publications, physician news magazines, and an online healthcare portal experiment. He has helped redesign and launch several medical and nursing journals and managed the development of a multimedia interactive curriculum in critical care. After Michael's presentation, you will hear from Zara Marcelian, Chief Executive Officer of La Maestra Community Health Centers. Zara will provide more information on the importance of health literacy for community health centers. Zara is the CEO and co-founder of La Maestra Community Health Centers, an FQHC providing healthcare, enabling, and social services to help the underserved immigrant and refugee residents in inner-city San Diego to become healthy and self-sufficient. Since 1990, La Maestra has expanded to serve over 40,000 patients per year in several areas of San Diego, including City Heights, El Cajon, National City, and Lemon Grove. Zara holds a master's degree in organizational management, has been actively involved in healthcare, education, community organizations, and other nonprofits for over 25 years. She is a member of the American College of Healthcare Executives, graduate of the National Association of Community Health Centers Excel Leadership Program, and the Phil Stone Foundation Executive Learning Program. And she also is a dedicated member of several boards of directors in San Diego and former president of the Council on Community Clinics. Next, I just wanted to mention the objectives for today's webinar. After attending this webinar, participants will be able to define health literacy, describe the importance of improving health literacy, explain the relationship between health literacy and health disparities, identify strategies to improve health literacy among low-income and immigrant populations, and discuss the Institute for Healthcare Advancement's What to Do for Health book series. Just a reminder to everyone, we will allow time for questions and answers at the end of today's webinar. So please type any questions you may have in the chat box on the right. And now, Michael, I will turn the presentation over to you.
Excellent. Thank you, Johnette. I sure appreciate it. And thank you, everybody, for being here. It's a real privilege to be asked to come here and speak to you today. We're going to talk about health literacy, and hopefully we're going to get into some very specific solutions and things that you can do to ensure that your message gets communicated. That is sort of the bottom line of health literacy, is to ensure that people have access to the information that they need to be able to make those decisions in the healthcare arena appropriately. So without further ado, I am going to jump in here to the presentation. I think Johnette already mentioned here some of your objectives for today. It's always a good idea, I think, to start off with some definitions, and so we'll jump right in here. When people say literacy and health literacy, they say, well, how does health literacy really differ from literacy? Here's your definition of literacy, or a definition of literacy: using printed and written information to function in society, to achieve one's goals, and to develop one's knowledge and potential. It's really your ability to function in our collective society. It's your ability to read a street sign, understand a bus schedule, look at a price tag on a supermarket shelf, read a newspaper, watch a television show, discuss that. It's be able to use the written, printed, and oral information that we get in order to function together as a society. Health literacy is a little bit different. It's kind of a subset of that. The main definition that you've probably seen before from Ratson and Parker: degree to which individuals have the capacity to obtain, process, and understand basic health information and services needed to make appropriate health decisions. So this definition is pretty good, but the problem here is that it puts the burden of understanding that information all on the recipient or the patient, the client, the healthcare consumer. This second definition I actually like a little bit better because it provides us with a little more shared burden for that communication. This second one, this one from the Calgary Charter on Health Literacy, defines health literacy as allowing the public and personnel working in all health-related contexts to find, understand, evaluate, communicate, and use information. It's the use of a wide range of skills that include reading, writing, listening, speaking, numeracy, and we'll talk about that shortly, and critical analysis, as well as communication and interaction skills. So it gets on both sides of the equation, the healthcare system as well as the consumer or patient side. And so that one I think is a little better, more effective definition. Plain language. Essentially, plain language is something that you tell people that they can understand the first time they hear it. It's just plain words. No jargon, no fancy double talk, just straight communication. And I'm not going to read through all of these, but this is a few of the points toward toward plain language. This comes courtesy of the CDC. So let's jump right in. What all are the pieces of health literacy? Reading and writing, those are pretty obvious ones, but also listening and verbal communication. This is when we're talking. It's also called oral literacy or oral health literacy. If I'm a physician, you're a patient, and you come into the room, or I'm a nurse, and I'm trying to communicate with you, I'm a health educator trying to tell you about how to manage your chronic illness, I need to not only speak to you and tell you things that I believe you need to know, but I need to be able to listen to you and hear what your concerns are. And if I'm asking you to repeat back to me what you think you've just learned, I need to be able to listen to that very critically and understand if you really understand what I've told you. So the listening and the verbal communication, two-way street, is very important in health literacy as well. Numeracy is a very important concept. This is essentially your ability to use numbers to understand risk and to figure out things like dosages. If I tell you, or if your prescription says you need to take this medication 4 times a day, when are you going to take that? In general, you probably want to have those times that you're taking that medicine spaced out very evenly. And so there's going to be a little bit of a calculation there. If your medicine says you can take 200 milligrams of this, but don't exceed 2,400 milligrams in a day, there's a calculation that needs to take place there. How many of those can I take, and how many are safe and effective for me? And then also health literacy also includes self-efficacy, which means your ability to manage something, take care of something, whether that's your diet, whether that's a chronic illness, if it's medications. It's your ability to do something that that is good for you or you've been requested to do that's going to contribute toward your health and well-being. Other considerations within health literacy are culture and belief systems. We all come from different backgrounds. We all have different experiences. So the things that we believe in, the things that we understand, our previous experience that we're bringing to the healthcare system is going to be different for everybody. And culture plays a big role in that. Our belief system plays a big role in that. Our all of the experiences we've had in our lifetime. If I grew up in an Asian culture, the way I look at healthcare may be very different than if I grew up in a Western culture, just as an example. So all of these parts play a role in health literacy. The mismatch, what we call the mismatch between what we are asking patients and clients to do and what they are actually able to do, is a very important concept, and we'll be talking a little bit more about that later on. The mismatch between the reading level of the recipient of the materials and the materials themselves. Most people are really not reading much above a 5th to 8th grade reading level. Most health information, printed health information, is written at a 9th to 12th grade level or higher. So there's a big mismatch in the materials we're giving to people and what we're asking them to do. Health literacy has a strong relation to health disparities, which we'll explore a little bit more shortly. It also has a very strong relation to safety and to quality. So here's one little suggestion for you. When you're speaking with people at your organization and you want to start to implement some of these programs, if there's any kind of cost involved and they're saying, well, health literacy is nice, but we really can't afford to to spend that money, let them know the correlations here between health literacy and health disparities, and especially between safety and quality. safety and quality in healthcare are just must-haves, absolutely cannot do without sorts of conditions. And health literacy is a very strong contributor to those. So if you bring up safety and quality when you're talking about health literacy, you may have a little easier time getting any kind of minimal expenditures that you need to have implemented there. So when we talk about health literacy, we know what we mean, but do your patients understand? Now here's a great picture of the guy sitting there saying, my doc said only 1 glass of alcohol a day. I can live with that. What's the missing piece of information here? That would be the size or capacity of the glass. Maybe 2 ounces of alcohol, or 4 ounces of wine, or 1 12-ounce beer is acceptable. That looks like it's probably about 1.5 gallons of hard liquor. Probably not a good daily allotment for alcohol. So again, when you say things, we have to be very careful in guarding against making assumptions. We have to be complete. We have to make sure that we are giving the complete message, and don't make any assumptions about what is not said. Here's another example. An 89-year-old man with dementia is diagnosed with an ear infection, is prescribed an oral liquid antibiotic. His wife understands that he must take 1 teaspoon twice a day. After carefully studying the bottle's label and not finding administration instructions, she fills a teaspoon and pours it into his painful ear. You know, when people talk about things like this, it's sort of like, well, you know, that was really her fault. She wasn't very smart. She didn't, you know, understand how this all works. You know, these are stories that happen all the time, and these are people who are doing the best with the information that they get. Now, is this person, you know, is this person stupid? Well, you know, no, not necessarily. I mean, she may be, but from this particular story, we cannot conclude that. What we can conclude is that she looked at the bottle with the medicine in it, and the bottle did not provide her with exact, accurate, direct, plain, clear, easy to understand instructions on how to give that. So she did the best she could. Sometimes doing the best you can does not produce the desired result. But these are stories that happen all the time. Here's another one as well. Mr. G, 45, Hispanic immigrant, native Spanish language speaker, has a job house screening. He's told his blood pressure is high and he can't work until it's controlled. He's given a beta blocker and a diuretic and instructed to take each once a day. 1 week later, he presents at the emergency department. His blood pressure is very low and he's dizzy. The doctors can't figure out why. A hospital Spanish language speaker asks him how many pills he took each day. 22, says Mr. G. In Spanish, once means 11. So here's a person who looked at that prescription bottle, understood 1 single word on that in his language, even though it was all written in English, once. And he made the assumption that that's what it was. He couldn't understand anything else but that 1 word, which also happens to be a word in Spanish. He took that and did the best that he could. So the question may arise, can limited health literacy kill you? In this instance, it very well may have. But these are just a couple of real-life stories that illustrate why it is so important for us to take into account the informational needs of the people that we are serving. At a teaching hospital, intern writes in a patient's problems section of the medical chart, speaks no English. The attending physician writes a note back in response, your problem, not his. The fact that people are not able to communicate with us in a manner in which we would prefer to communicate is not a problem. It is a barrier. It is a challenge, and it is something that we need to address in order to ensure that they have the information that they need to understand completely their current situation and to act upon that situation in the way that we are instructing them or suggesting that they act upon it. So if somebody doesn't speak our language, that's a barrier, that's a challenge, and we need to rise to that occasion. We need to get an interpreter in there. We need to take some steps to ensure that we can communicate. This is not a problem, it is a challenge, and it's one that we need to address. So we have a poll here, and I'm not sure, Johnette, if we have an ability for people to do this, but with our limited time, I think we'll just go forward with this. Which of the following is the strongest predictor of an individual's health status? Is it age, income, their literacy skills, their employment status, their education level, or their racial or ethnic group? And, of course, the answer, C, literacy skills. Of course, this is a webinar about health literacy, so yes, literacy skills is the strongest predictor of an individual's health status. In fact, 75% of those who self-reported, or basically said, I have poor health, fell into the below basic health literacy category. So this is a very strong predictor. If people say, I have very poor health, that is a very strong predictor that they likely have very limited health literacy skills. Here are a few myths about health literacy. I'm not going to go through all of these. Maybe you might want to go back and take a look at these. In the interest of time, I want to move forward here. But there are plenty of myths surrounding health literacy. I want to talk a little bit now about health disparities in health literacy. Again, good time to start off with some definitions. Health disparities are essentially differences in the incidence, prevalence, mortality, and burden of diseases and other adverse health conditions that exist among specific population groups in the U.S. This second one is probably the most straightforward one, a population-specific difference in disease, health outcomes, or access to care. So it's not only clinical measures, but it's also socioeconomic measures. It's also health care system resource measures. When people are exposed to or are, I don't want to say victims, but are under the effects of health disparities, you will see things such as they have restricted access to health care services. And this may be whether they have insurance or just because of their location. It could be a number of different things. Health disparities also includes unjust or preventable inequities, which means the quality of the care or the level or the type of care that they are allowed to have access to. Health disparities disproportionately affect minorities, those living at or below the poverty level, and those with low education. And health disparities really is a shared responsibility among the system, the healthcare system overall, providers, and patients as well. Everybody has a role in this. Everybody is has a part to take in this to ensure that we minimize health disparities as much as possible. So what are some of the connections between health literacy and health disparities? Those who experience health disparities and those who have limited health literacy share these particular characteristics. There really is a low systemic awareness of this particular problem. Most people nowadays, the awareness of health literacy is getting better. I noticed when I was looking at some of the results from the poll from those who registered here, and more people than not said that they at least had a pretty good awareness of health literacy, which is represents a big change from a couple of years ago. So we are having some success in raising awareness of health literacy. Those who experience health literacy and health disparities tend to have lower access to usable health promotion materials. They are disproportionately represented by, again, those living at or below poverty level, those experience language barriers, low education, and those who have some type of disability. Those who experience limited health literacy and health disparities have lower rates of they are insured at a lower rate and tend to have less access to health care, and they also tend to be victims of poor cultural competency, which is a whole other area we could sit here and talk about for hours and hours. But this is essentially a lack of racial and ethnic diversity in the healthcare system, or at least if I would like to have someone as my caregiver who is of a similar racial or ethnic or age or gender background to myself, if I am a minority or I'm in an area where people such as myself are not the majority, I will tend to have many fewer choices in terms of who takes care of me. Higher hospital admission rates, poor quality health care, and this is what's interesting about the poor quality health care. That's not only measurable statistics, but that's also perception. And we also see down here perception of unequal treatment, but also perception of poor quality health care. If I feel that I'm receiving poorer care because of the who I am or the type of insurance I have or how much money I make or what race or gender or age I am essentially a victim of a health disparity. And that is an inequity and injustice that does not need to exist. And we can see the rest of the other connections here. We are going to move a bit now very quickly through some data sources. When we talk about health literacy, the question always comes up, well, really, how pervasive is this problem? I know it's just that group of folks over there. and those are the ones that are experiencing some of the problems. But it's not really me, it's not really the people that I serve, and it's not the people who I come in contact to. That's another myth, and we are going to dispel that myth. Here's the data sources for where we got our actual information. The one we're going to concentrate on is the NULL, which was done in 2003, and that one had a health literacy module added to it, which the NULLs in 1992 did not. 4 literacy levels: below basic, basic, intermediate, and proficient. Essentially, in order to function in the healthcare system, you need to be at the proficient level. If you are any of those other 3 categories, you will have challenges dealing with, navigating, and utilizing the healthcare system, as well as issues with self-efficacy, particularly in the area of managing a chronic illness. The NULL, in terms of the literacy findings, we'll look at health literacy in a moment, but in terms of literacy, here are the rather shocking findings. The percentage of the adult population that fall into the bottom 2 categories, below basic or basic skills. Prose, which is your ability just to read a sheet of paper, sentences, and paragraphs, 44%, almost half of the U.S. adult population fall into the bottom 2 categories in terms of literacy. Document literacy. This is your ability to fill out a form, read a chart, find your BMI on a chart, find a dosing amount on a chart based on height and weight, read a bus schedule, anything that's like a chart or a graph, anything along those lines, or a form with little separate boxes on it. That's document literacy. About 1/3 of the U.S. population fall into the bottom 2 categories. And quantitative literacy, also known as numeracy, which we talked about before, your ability to work with numbers, add, subtract, make simple calculations, understand risk, all of those sorts of things, percentages. More than half, 55% of the adult population fall into the bottom 2 categories in those areas. Now here's the health literacy findings. 36% of the adult population have limited health literacy skills. Let me say that again. 36% of the U.S. adult population have limited health literacy skills. They fall into the 2 bottom categories. Only 12% of the adult population are considered proficient. And as I mentioned before, in order to effectively navigate and function in the U.S. healthcare system, you need to be at this proficient level, and only 12% of us are. This also includes 3% who did so poorly on the basic screen they had to go to an alternative. Does not include the 2% who knew no English or Spanish. About half of the, little more than half of the U.S. population is considered intermediate, and women's health literacy scores are 6 points higher. Big surprise. So who has poor health literacy? Who are the people who are falling into these categories? There are a few groups here which are a little more disproportionately represented. However, this does not mean if you are in any of these categories that you automatically have poor or limited health literacy. People in these groups, as individual groups, tend to have a little more representation in those bottom categories of health literacy. Those who are 65 and older, about 60% of them fall into the bottom 2 categories, basic and below basic. If you get health insurance from your employer, as a group of people, you would tend to, as a group, have higher health literacy. If you are on Medicare and or Medicaid, or you have no insurance, as a group, you would tend to have poorer or more limited health literacy. And you can see the statistics here for Hispanics, those living at or below the poverty level, disproportionately represented in those lower levels. And again, as we mentioned before, 75% of those who self-reported that they had poor health fall into the below basic health literacy. Again, these statistics are all one so that when you encounter any of these particular groups, it should just be a little red flag for you to say there's a greater likelihood that the person I'm dealing with here has limited health literacy skills. Although we strongly, strongly suggest that you just always automatically assume, you know, these people that I'm dealing with, this particular person here, let's just assume that they don't have great health literacy skills, so let's communicate clearly. Let's use plain language. A few more statistics. 1 in 2 Americans are not really reading above a 5th grade level, and we mentioned about the patient education materials already. 26% of those, and these next three were from an AMA study, or a study published in JAM, I should say. 26% could not understand when their next appointment was when they were given a written card that said, here's when your next appointment is. 42% could not understand the instruction, take this medication on an empty stomach. And 60% could not understand a consent form. I submit to you that that number 60% is low. That's probably more around 80%. Have you read a hospital or a procedural consent form lately? Terribly, terribly high language level, very convoluted language and syntax, and very difficult to understand. A few more facts here I'm not going to spend any time on, except for this very last one, which is a very insidious one. 75% to 90% of patients in the 2 lowest reading levels described themselves as being able to read or write English well or very well. So there's a phrase which was a title of an AMA video called "You can't tell by looking." This is very true. And nobody is going to tell you, I'm sorry, I have very limited literacy skills, so can you speak in a little more easy to understand language, or could you have a version of this that I can actually read? That's not going to happen. Also, in case you're wondering about that acronym there, LEP, 24 million Americans, that's limited English proficiency. Cognitive impairment, meaning your ability to think clearly, can also affect your health literacy. Hearing, visual impairments, if you're on medication, any kind of stress, and then also shame. I mentioned about people not mentioning that they have limited literacy skills. They are not going to tell you. That just simply is not going to happen. Here are a few things that patients may say to hide the fact that they have limited literacy skills. I forgot my glasses. Now, they may have, in fact, forgot their glasses. But if you hear any of these types of phrases, that may be, again, a little red flag, a little warning sign that you may be dealing with someone who has some literacy issues. So why does all of this stuff matter? Well, it matters for a lot of reasons, mostly because limited literacy skills, health disparities will tend to increase human suffering. And if for no other reason, that should be a reason why it matters to us. However, here are a few more reasons. Those with limited literacy skills tend to report overall poorer health, as we mentioned. They have a poor ability to manage their chronic diseases. We spend 75 cents of every healthcare dollar on chronic diseases. And if people have trouble managing those chronic diseases, that has a big impact on the healthcare system, and it's a big drain on our resources. Those with limited literacy skills have poor outcomes. They're less likely to understand their diagnosis, less likely to have screenings or undertake any kind of preventive care. They'll present later in diseases, in the stage of disease, which is only going to increase the cost of treating that. And they are more likely to be hospitalized. And when they are discharged, they are also, as a group, more likely to be re-hospitalized. So here are some actual dollar numbers when we get into that side of the equation. Some earlier studies in health literacy attributed about $73 billion spent unnecessarily because of limited health literacy skills. Vernon at UConn in 2007 published a study that showed that figure could actually be closer to $250 billion unnecessarily spent each year because of our inability to understand materials, and on the healthcare provider side, our inability to communicate clearly and ensure that our message is being received. $1.7 trillion again spent on chronic diseases. That's about 75 cents out of every dollar. Nearly 1 in 2 Americans live with a chronic disease. So you can start to see some of the connections here. 90% of those 65 and older have a chronic disease, and 77% of those have 2 or more. So let's remember back to the statistic that said those who are 60% of those who are 65 and older tend to fall into the bottom 2 categories of health literacy. So what we're really looking at is those who most need to have good health literacy skills tend to not have them because of the number here of people who have the chronic disease. So here's a group that's utilizing a majority of the healthcare resources, but they are the least equipped to be able to do that effectively. And chronic diseases account for about 7 out of 10 deaths annually. So towards solutions, here are a few things that we're going to talk about that you can use. Some of these are more from a strictly an educator point of view. Some of these are more from a provider or clinician point of view. I'm going to try to move through these fairly quickly just to introduce them. You'll have these on your slides later on, so you can always come back and refer to them. But I just want to make sure I'm giving adequate time to everything here. So under design considerations, make sure if you are either designing materials or if you are evaluating the materials that you are going to hand to your clients, to your patients, that they follow most, if not all, of these particular considerations. A large type size. Don't do anything smaller than 12 points. 14 points even better. Make sure your lines are double spaced. Use a standard font, meaning no italics or all caps. All capital letters are remarkably hard to read. If you have to capitalize one word, that's okay, maybe two, but don't do a whole sentence, and good God, don't do a whole paragraph or a whole sheet all in caps. Nobody's going to be able to read it. You really only need two typefaces, Arial for your headings and a serif type such as a Times New Roman for your body. So on the slide you're looking at, the words tools and techniques, that is an Arial heading. That's called a sans serif type. And then the rest of the slide here is a serif type. That's a Times New Roman. So those are really the only two that you need. Use simple headings. And when you use headings, so if you're talking, if you have a sheet or two, use a little heading to let people know what's coming up. People who are poor readers don't like to read because they're not good at it. So the more that we can, the easier we can make it for them to read those particular documents and to make sense of those, the more likely they are to continue to read and actually to retain, comprehend and retain some of that information. So let's help them out by doing a little bit of work ahead of time. Add those headings in so that prepares them for what's coming up. White space is good. White space is all the space on your page where you're not putting stuff. It's just the empty part of the page. Again, people who are poor readers can look at a sheet of paper and go, oh my gosh, there's so much stuff crammed on here, there's no way I'm going to be able to read this. If you leave a lot of white space, there's maybe a little bit greater likelihood that they're going to look at that and say, this might not be too bad. I think I can do this. A lot of white space. It's going to help you in the end. Usable and appropriate explanatory graphics. Put the graphic right next to the copy that you're talking about and have it explain directly what it is you're talking about. Short sentences, 8 to 10 words, maybe 15 max, but keep them short. Use columns. Columns are interesting because if we put our copy all the way across the page, and I'm sure you guys have, I do this all the time. You're reading all the way across the page, you come back to the next line, you're reading it, and you're going, wow, this sounds really familiar. Yeah, because I just read that line. I went back and I went up a line. So if you use columns, there's a shorter distance that they have to come back, left, right, and a less likelihood that they're going to either skip down an extra line or go back up a line. Bulleted lists or texts, which is chunking, which you actually see here. This is a bulleted list of 4 items. But really keep those bulleted lists to no more than 7 or 8 numbers. And how to or need to do. Those are the things that you want to make sure you put in your message. Try to keep the nice to know information to a minimum. Give them the how to, give them the they need to do, and do it in an active voice. Remember from your English classes when you were in grammar school, active voice is your subject and then your verb. John threw the ball. That's an active sentence. The ball was thrown by John. That's a passive sentence. So you always want to make it active. Put your subject first, the action that they're doing, and then the rest of the information there. And this is just a repeat, so we can skip that slide. So here's a couple of quick examples. We're going to talk about the What to Do for Health books. We are a nonprofit organization, by the way. These are books that we sell to people who want to make sure that their patients, their clients, their members are getting easy to read and easy to use materials. As you can see from this particular page here, we've got our bulleted list. We've got simple, short sentences, no jargon, and we have the little explanatory graphics right next to a number of these particular ones. So this is a good example of a patient education material that works very well. Here's another great one. This one's published by the American College of Physicians Foundation, and they're talking about portion sizes. Now, a couple of things that you'll notice here. The cultural and age and gender mix is quite good. We have a male and 2 females. We have a good mix of kind of younger, middle-aged, and older. We have a good racial, ethnic mix here. The reason you want to be able to do that is you want your readers to be able to identify with the graphics that you're showing, with the people there. So if I am an African-American woman in my 20s or 30s, I can identify with somebody on that page. If I'm a Latino male in my 30s or 40s, I can identify with somebody on that page. So, and the other nice thing about this particular page, I don't like the italics in the middle, and they've actually subsequently fixed that in the new version of this publication. But they also show the graphics. So in the first one, you say she's talking about the correct portion size of meat. It's about the size of a deck of cards. There's a great picture. She's putting a deck of cards. I don't know if you need to put the deck of cards right next to your steak when you're cutting it, but that at least shows it. And then there's a few other tips about portion size, and they're showing you the graphics there. So you're not relying just on text. You're looking at graphics as well. You have supporting information to help convey your health message there. There is a communication device known as a photonovela, also spelled F-O-T-O. But what this does is it tells a story, and it uses people who are in the target group of the to whom these pieces are going to be distributed. So this particular one talks about Tanya's journey to a better life. Tanya is from, I'm not sure where Tanya is from, but she has moved to Canada, and she's talking about how she has a bellyache, and the woman says, I think you should talk to your teacher, and the teacher says, she says, why am I feeling bad? She says, maybe you're not eating well. And she says, but I'm eating Canadian food. The teacher says, you need to eat healthy Canadian food. So the thing goes on with additional pictures, and the nurse comes in and explains what the difference is between healthy and not healthy food, and Tanya learns her lesson, and everything's happily ever after. These are actually particularly good in dispelling health myths. So for instance, in certain groups or populations, they may believe certain myths about something like having a mammography, and you'll use people from that particular group saying, oh no, I had it, it was fine, and guess what, I found out that I had this little tiny thing, they treated it, and I'm fine, so I'm really glad that I did it. It tells a story, it teaches a lesson. I don't know if we have enough time to do a critique on this one. If we do, Jeanette, maybe we can come back at the very end, but since we're not really doing interactive here, I can just say, if you look at a sheet like this, first of all, I hope nobody is here from the Children's Hospital of Philadelphia, and if you are, my apologies. But you can see, again, very tiny type, no graphics. The Q&A, that ampersand for the and, is so huge it almost doesn't even look like a real character. And the thing that this is actually about is so hard to read up there, the facts about childhood vaccines. And if you read the type, the copy, it's very hard to read, very high grade level. Here's a book I recommend everybody take a look at. You can actually get a free copy of it from that website. This was written by the Dokes. And also, if you happen to attend our health literacy conference, we give you a free copy of this book to all attendees. Universal precautions, we talked a little bit earlier about about making the assumption that everybody has limited literacy skills when you're communicating. And so that's what this is about. Assume everybody has that low-grade reading level. Include all of your stakeholders in your planning. Limit your key messages. Don't say, what questions do you have? I mean, don't say, do you have any questions? Ask them. I know I've gone over a lot of stuff here. I know you have a lot of questions. What's the first question that's on your mind? And there's a web address for you to get the Universal Precautions Toolkit. Use plain language. Don't use medical jargon. Slow down. Don't talk as fast as I'm talking. I'm only talking fast because I want to make sure I get through in plenty of time. Use living room language. That's the language that we use when we're just sitting around at home talking to one another. We don't use fancy language when we're talking to one another. When we talk about test results, we talk about we use words like benign, negative, at risk. Do you realize that every application in the English language, negative is a bad or not a good word, except in healthcare. In healthcare, negative is a good word. So we need to change that. Don't use those. Just say if the test results came back, yes, you have blankety blank, or no, you don't have blankety blank. Here's some medical jargon terms and some very simple alternatives. Again, I'll let you look back on this a little later on. Enough with the English. Give it to me in plain academic medical terminology. Yeah, that doesn't happen. That just doesn't happen. The teach-back method, I'm sure a lot of you are familiar with this. This is essentially asking people to repeat back to you in their own words what it is that what it is that you've taught them. And you keep listening, and if they get something wrong, you say, I'm sorry, you did a great job except for this one thing. I didn't do a very good job explaining that. Let me go back and explain that part again because we're not on the same page on that one. And then go over that part again. Then ask them to explain back to you in their own words what it is you've told them. The brown bag test, this is a clinician's tool. You're asking people to bring all of their pills and medications into the office visit with a brown bag, any kind of bag. It's just called the brown bag test. It's a good drug interaction opportunity to see if they're taking drugs that have interactions. Also test their understanding of what the medicine is and how do they take it and why do they take it, or even are you taking this medication. It's a good chance to look for expired medications, and also if they tend to open up the bottle and look at the pill rather than reading the label, that's a good indication that you may have some literacy challenges there. Here's a few other ones, the Ask Me 3 and questions. And then these are some books that we publish. These are all written at a 3rd to 5th grade reading level. You can see all the various titles there. These are good in-home solution for health issues. Lots of diagrams and illustrations. And there's actually been some other studies done by groups other than us that showed once people were given these books and shown how to use them, that there was reductions in unnecessary visits to the ER, visits to the doctors and clinics, fewer missed school days because of children, and fewer missed work days because of the parents having to stay home to take care of the children. This is because this talks about the 50 most common childhood illnesses and injuries and tells you what you can do at home and when or if you need to go to the doctor or to the emergency department. These are outside studies, and they really show that these books are effective. And there's also, we have on these particular books as well, there's various distribution methods that you can use. You can mail them, you can hand them to them. We have a free curriculum you can use to teach people how to use this book in a class. Remember, people who are poor readers don't generally use books as their first place to go for information. So if you distribute the books in a classroom setting, you can actually walk through and show them how to use these particular books, and they're actually quite effective. Here are some other resources that you might want to explore. And with that, I'm going to turn the meeting back over to Jeanette. Thank you very much.
Thank you, Michael. Thank you, Michael.
Yes,
Zora,
you're welcome.
I'd like to turn the presentation over to you.
Hi, my name is Zara Marcellian. I'm the CEO of La Maestra Community Health Centers in San Diego, California. Our name La Maestra means the teacher, and the reason we decided to keep this name was because we knew that if we want to affect any change in the community among any cultures, it comes through education, the message, how you deliver the message, how you form the message, and so forth. We had a nonprofit educational program for 12,000 students back in 1986 where we offered English as a second language, vocational training, preschool. We had a licensed preschool. We had computer literacy. We did teaching students basic English, civics, and history so that they could pass the amnesty test that was offered through the IRCA program back in 1986. That's the Immigration Reform and Control Act. So of those 12,000 students, 9,000 did become permanent residents, and they went on for citizenship and other adjudicated classes of visas and so forth, including political asylum, and there's plenty of other programs associated with that. But again, through those programs that we offered in services, we were able to identify, and the Student Council also met regularly and said, we need health care in our community that is culturally competent and delivered by people who, or providers who recognize that there are different ways of thinking, and and that's okay, and that they enjoy working with us. And hopefully we would find providers that speak our language, or medical assistants, dental assistants, psychologists, or numerous providers that hopefully would become trained from those different cultures. So that's just a little background about La Maestra. So if you look here on the circle of care, that is the colorful slide with looks like a lot of a big flower there. We tried to now group the services that we provide. Many of those services we kept from the Amnesty Center and moved them over to the clinic. that we formed in 1990. And now we have, so we have like a food pantry, we have a community garden, we've got microcredit programs, micro enterprise, housing assistance, transitional housing for folks that are in recovery, aside from all the medical and very comprehensive medical services too. And I guess our niche all along, being here on the border, well, I should say, being in the border zone, many people think, well, gee, maybe we're just, dealing with lots of Latinos. Well, we are majority still Latino patients, but we have tremendous amount of refugees, and refugees have been settled into our areas in the different communities that we serve. We've got 6 clinics around San Diego County, and we're in 4 schools because the the voluntary organizations like Catholic Charities and International Rescue Committee, they place the refugees in centrally located areas where there are other cultures that they can interact with, and they don't feel like they're totally isolated or the only foreign group. Also around, they want to locate them around ethnic-based supermarkets so they could find their food and herbs and spices and so forth. Some of the the issues that we've run into here, and it shows you here the slide serving the culturally diverse community, gives you some background also here, some stats on our patients, especially the 91% of patients prefer to communicate in a language other than English. We train as many cultural liaisons in those different languages as we can. Those that are interested in becoming medical assistants or pharmacy techs or dental assistants or lab techs, anything like that, and health education, of course, because there are many people looking for job training and jobs that are interested in these positions but don't have the training, in English, or maybe, they were licensed physicians in their own country, but it's impossible for them, some of them, to pass because of the English proficiency level. Their boards here and their tests to become providers and lab techs and so forth in the United States. So they will settle for other positions like health educators and, helping with case management, eligibility workers, and so forth. So we try to identify those within those different cultural populations that we serve and then provide them extra training. And we've done a lot of curriculum on, how do you train, medical assistants or CNAs or so forth. That helps us. It helps our patients, especially when our patients go to the specialties that are not available at our clinic or the hospital. Sometimes, I just want to add a couple of common occurrences. Like in our Elkhorn clinic, we have a lot of Arabic speakers, Chaldeans, other Iraqis, and Pakistani, Afghani, and they will come into our clinic, and they'll say, you know what, I just came from the hospital, and I don't know what happened. Went there. Can you tell me what they did to me over there and why they gave me this medicine that I don't know how to take? I mean, this is amazing to me that this is still happening, and we have reached out to our local hospitals. And depending on the awareness and openness of the administrators of today, they would be, welcome for us to go in and do training. We've done training in their labor and delivery rooms with their nurses on, why different cultures prefer to deliver, like in different, like, they don't want to be strapped down. They don't want to just lay there until they're going to deliver. They feel that that's going to be harmful for the baby. And so we could try to educate them on these things and ask them questions, about, differences that they've noticed, when we send our patients over. Also in all of the other emergency rooms and so forth, because many of our patients would say that they would be waiting in the waiting room, much longer than anybody else. And we knew that waiting rooms can take a long time in the emergency room, but This was, extra. And why? Because the staff really didn't know how to deal with our patients. So we went and did training over there. But then, that has to be ongoing. There's always new people being hired. There's always constant turnover, and that's something that I would encourage. If you have good relations with your local hospitals, if there's some way that you can go in and establish that rapport, it makes it so much easier for your patients when they end up in those other settings. We also use plain language. We do some translation of the required language, like we do mammography here at La Maestra. And there are certain letters that we are required to send to the patients with certain verbiage dictated by the accrediting body at the Department of, in California State here, that governs mammography and radiation, or radiology, I'm sorry. And so we go ahead and we issue that letter, but underneath we put it in the plain language. So that way we're compliant with the state requirements, but we also address the need for plain language with our patients. We do use universal symbols and signs. We use tons of visuals, and that can be flip charts, can be plastic, like plastic foods and things when we're teaching nutrition. I'll give you an example here. Many patients in nutrition classes have a hard time understanding fat content in foods and portion size. So the health coach uses a flip chart with different food images and yellow cubes representing fat to demonstrate how much fat is in the foods, and simple everyday objects to represent portions. And then the health coach notices the impact it has in their understanding of nutrition, versus a simple handout. And then, of course, they ask them to teach them back some of those points and ask questions so that you see if people are tracking or not. We do similar flip charts when we're talking about, or we're talking prenatal classes with, let's say, Burmese patients, Somali, Sunnis. We use lots of flip charts and images when educating on healthy exercise, food portions, baby development, car seat safety, and our cultural liaisons are always present to translate and add to that information, to those pictures, and then be able to tell us the questions that the patients are asking back after they're looking at this. I think, I spoke with some of our patient care advocates. They do the education. They help people navigate through the system also. And one of our, Julia said, many times we realize a patient can't read when they hold a document upside down. So we try to be sensitive and patient and offer to explain it to them verbally instead of asking them to read it. We also ask them questions to make sure they understand what we told them. So that's, super important. We have found also prescription. We have a pharmacy, so we do the different labels, the prescription labels in some of the major languages that we have. Obviously, we can't do them in all of the languages, but that's been working really well. We have to do English and Spanish or English and Arabic, and that will work great. Another thing is that brown bag. Many of our providers ask the patients, especially when they're new to us, to come and bring every other prescription that they have, because many of these populations have moved around and have been given different prescriptions for different things by different providers. And unless we know what it is that they're still taking or not, it's really important for them to bring everything in and make sure that we're not creating more of a problem here by just assuming that that they've not been anywhere else for prescriptions. Also, some of the pharmacies, not ours but others, once they're ordered, once there are prescriptions, let's say on high blood pressure or other chronic disease medications, they will continue, the pharmacies will continue to send and deliver to those patients' homes just forever, and regardless of the refill, whatever. And the patients, we've had some patients out in El Cajon that have come to us, and they say, you know, I got like, you know, 20 bottles of this when I was living over in some other area, and the pharmacy would just keep delivering them to my home, and gee, you know, I'm thinking maybe I should just go sell them at the swap meet or something. Different cultures that haven't been here a long time, they don't understand, you know, why that wouldn't be a good thing to do. So it's good that they ask us these questions. It's good that we ask questions in a culturally competent, sensitive way. And that brings me to the point of how you draft the message. And our media especially, or public health, Department of Public Health, when they put a lot of money behind a certain, you know, epidemic like oral health epidemic, we have to educate the whole county. And then they put messages, important messages about health on the back of a bus. Many of our cultures will not know to look at the back of the bus, like they would never think of that, to be a place where they should pay attention and actually think about that important health information. They just would never think to find it there. They have to be approached in a different way through the elders of their community, their churches, and so forth. And then when you get permission to be able to come in from those elders to give this information, then it's great. You can do train the trainer, where you train different people who are more English proficient in delivering this health education. So when you leave from that community, you know, let's say you're on a health fair or you're doing outreaches there, there's somebody there to continue on this, you know, the effort. We've also used fotonovelas, that kind of like soap operas, and it's very helpful with teens and adolescents. We've found that they're very attracted to this model. So we talk a lot about domestic violence, you know, what that is, what are some signs, human trafficking, because we do have victims of human trafficking here, as for the sex exploitation as well as the labor exploitation. The myths are very important to dispel in those fotonovelas, like chronic disease. Some of our populations, when they first came over, thought that the test for diabetes would actually give them the disease. So that was super important for us to find out from those cultural liaisons, so that we just didn't use the same cookie-cutter approach with all of our populations in terms of how you roll out the message and the health education materials. Let's see. And then I just wanted to say, you know, some of the examples of the health literacy, aside from those here on the slide, are, you know, depression, anxiety, dementia, Alzheimer's, substance abuse, and many other health education topics that are so important, and to remember that many of our populations have not had years of preventative you know, treatment or prevention, like with the oral health, or you know, going to see doctor regularly. So that's really important to note, and that's what many disparities I think are related to, because they just haven't had access, coming from countries that didn't have this these services. So now it's like catching up, and not only catching up in looking at all of the services they might need, but the health education, you know, the years that we've been hearing about, you know, why you need to go in for all your prenatal care, what's that going to be, what's the outcome, how's that going to affect your baby and his birth weight and so forth. I mean, we have had that for years growing up in this country, but many of these patients have not. And they've lived for years in refugee camps, what, of course, they've been deprived of many, you know, good nutrition, vaccines, so forth, medications. So that's what I wanted to convey, and thank you so much for letting me have the opportunity to share some of our experiences. And if you would like any specific information regarding this presentation, please don't hesitate to contact me on my email. Thank you so much.
Thank you, Zara and Michael, for such a phenomenal presentation. In the interest of time, we have had several questions come through. I will try to get to as many of them as possible, but if we are unable to answer your question at this time, we will be sure to get those questions out to the presenters so that they can answer them. So one of the first questions is, someone would like to know whether or not there are tools available to measure health literacy in people.
Yes, there are. There are some written tests that you can take, and before I mention what those are, I would very, very strongly suggest that you really ask yourself the reason why you want to measure the health literacy. There's a very strong movement within the health literacy community to go with this approach of universal precautions. People being tested for their literacy can sometimes find that to be very embarrassing. They can feel like they're being singled out, and especially if they do have literacy issues, it can be a very problematic process. That being said, there are a couple of written tests, the REALM, R-E-A-L-M, and the TOEFL, Test of Functional Health Literacy in Adults, are probably two of the more common ones. And there's also one called the Newest Vital Sign, NVS, and that's a test that you do. It essentially uses the nutrition facts label from an ice cream carton, and you ask them a series of 6 questions, and depending on how they answer that will give you an indication of their literacy skills. There's also a research study that was done that showed if you ask a single question, the likelihood that you'll find out if these people have poor literacy is quite good. And the question is, do you often ask for help in filling out forms? And if you ask that question and if people say yes, you probably have somebody who has limited literacy or health literacy.
Okay, great. Thank you. One of the next questions is, what is the difference between self-efficacy and self-responsibility in healthcare?
I don't know, Zara, do you want to answer that one? I'm happy to answer that one, but...
No, go ahead. That's fine,
okay.
Michael.
So self-efficacy is really your ability to do something. It's how well you are equipped and to do it, how well you're educated, and how well you've understood those instructions in terms of how to do that. So if I'm a newly diagnosed diabetic and I have to learn how to measure my my blood sugar, understand about my hemoglobin A1C and what that means and what I can eat and what I can't eat, understanding all of those things is a measure of my self-efficacy. Self-responsibility has more to do with a designation about whether something is a under my category, if it's something that I need to take care of. So again, with the example of a diabetic, eating well, you know, making sure that I test my blood on a regular basis, watching my weight, all of those sorts of things. Those are self-responsibility. Having the hemoglobin A1C test done and you know, on a quarterly basis and showing those results and seeing how I'm tracking over time. You know, measuring, looking in my eyes and seeing if I'm, you know, showing some signs of retinopathy or any kind of other degeneration, looking at my feet to see if any of the sequelae of diabetes are showing up there. Those are responsibilities of your primary care provider. So that's probably where I would show that distinction between the two.
Thank you, Michael. The next question is, who should determine the literacy barrier of the patient, the doctor or the medical assistant?
You know, again, well, I guess when you say the literacy barrier, I'm assuming you mean the literacy level, and that should really be a team approach. And again, I am just a very, very strong proponent of this universal precautions approach. If you are in speaking with the patient and you are using, you know, simple words, short sentences, speaking slowly, and not exaggerated, but just in a way where people can understand you, and the response back from the person is they have a high vocabulary, they're speaking very quickly, you have good eye engagement, they appear to be understanding everything you're saying, and they're asking questions that show that they've understood what you've said and they're building upon that. If you want to, you know, match that particular level of conversation, I suppose that's fine. I wouldn't have an issue with the medical assistant making that distinction and the physician making that distinction separately. But again, I think overall you should have an agreed upon approach in your particular facility as to how you want to do that, and I would strongly recommend that you use, and that toolkit, that Universal Precautions Toolkit that's available from ahrq.gov, actually has a whole program that you can implement within your particular facility. It actually has a testing one that tests how well prepared you are now, and it phases in all of these particular approaches in a kind of a stepwise fashion. So I strongly encourage people to look at those kinds of tools and implement those sorts of things. But at a minimum, just at least say we are not going to use a lot of medical jargon. We're going to provide our written materials at a 5th to 6th grade level. We're going to speak slowly. We're going to ask people to repeat things back. If we see people having trouble with forms, we'll offer them assistance in filling those forms out in a non-embarrassing, non-threatening way. So, you know, some of those sorts of approaches I strongly encourage.
This is Zara. I just wanted to add something that was useful for us. We started keeping track of the number of patient visits that were not comfortable, because there's another thing too. It's not just how much do they understand. It's like, do they really feel comfortable in having that visit be all in English without any interpreter of any kind. And so we started keeping statistics there and information back from the medical assistant or dental assistant or mental health assistant. They were like, you know, like our, what is it, marriage and family therapists and so forth. They would say, you know, this is a concern for the patient. They don't understand this, and you know, our culture is this. So it's really it's more than just determining the health literacy. It is also getting that understanding about what other barriers and challenges will be in the way because of the language and possibly religious and cultural beliefs that is going to get in the way of that primary care visit happening. And then document that and talk to one of the local foundations that might give you some funding to develop your health literacy for diverse cultures.
Good point.
Great, thank you. And Zara, this next question is directed towards you regarding the medically trained cultural liaisons courses that you offer. Someone wanted to know whether or not you have a community health program as a part of that program.
Community health program, yes, we do. We do community, like if you're referring to like regular outreaches, health fairs, going into like public low-income housing, regularly working with the tenants, a tenant representative, and community workers, promotoras, and they deliver regularly information on different, you know, health topics, and then be a way to bring the patient back to the clinic and provide that medical home for those uninsured and, you know, people out in the community that maybe don't have a regular provider. So we do, it's part of our overall system that we deliver health education.
Great, thanks, Zara. And again, in the interest of time, I will read a couple of more questions, but just as a reminder, we will make sure everyone's questions get answered. The next question is, how do you recruit a diverse staff when you do not have a lot of diversity already? So basically, what can you use to attract them to your center?
Michael, do you want me to answer this one?
Yeah, I think that's definitely one for you.
Okay. Okay. What we have done is we have identified among the communities that we work with, you know, build a relationship. So like if it's the Laotians or the Vietnamese or the Sudanese, so forth, we work with them on, you know, on other collaborations like, you know, health education and going out to their community and so forth. So it was very easy for us to have identified to us people from their community that were, let's say, in a position working in medical delivery system, whether in the refugee camps or back in their country. And that meant to us, okay, they're really interested, they understand how it is working with their populations, and then we would meet with them and provide them with other training about confidentiality and so forth. And it's really amazing how we've been able to build up a very, comprehensive, I guess, group of cultural liaisons.
Great. Thank you, Zara. One last question. Is there an evaluation tool that can be used to evaluate a health literacy intervention to find out whether or not it's actually working?
Michael, do you want to?
I'm sorry, Jeanette. Could you repeat it? I had my headset kind of went off for a second there.
Sure. Someone wanted to know whether or not there is an evaluation tool that can be used to evaluate a health literacy intervention to find out whether or not it's actually working.
Well, if we're talking about evaluating whether, when you say a health literacy intervention, that could be a number of different things. So, one of the tools that we always recommend people use when they are explaining something is that teach-back method. And Zara kind of referenced that a little bit. That's again where you do some teaching, you do some training, and you ask people, well, when you go home now and your wife is going to ask you what I told you, what are you going to tell her, or what are you going to tell your husband, what have you? And they'll repeat that back in their own words, and then if there's parts where that is incorrect, then you can teach directly to that particular piece. If we're talking about a printed piece, we can always evaluate the grade reading level is usually a pretty good way to do that. And then again, if there's an action that you are asking them to do, schedule a mammography, cut out alcohol, make sure that you increase, your half of your plate is fruits and vegetables. You can circle back with people and ask them, at a specific time. That's more of a case management kind of a function. So I guess when the question is about health literacy intervention, I'm a little unclear on what that is. But those are some basic tools that you can use to at least get a little closer to understanding whether there's comprehension and retention of the material that the information that you've passed along.
Great. Thank you, Michael. I just wanted to thank our speakers again for providing a phenomenal webinar. I hope that many of today's participants will find this information very useful. Just as a reminder to everyone, our 2013 Health Center and Public Housing National Symposium is quickly approaching. It will be June 4th through 6th at the Sheraton Downtown Denver Hotel. And if you have any questions, please contact Teresa Brannon at namgt.com. We hope you can join us. Thanks again to everyone, and enjoy the rest of your day.